Hello, everyone. I'm Dr. Carmen Pugliafito, and I'd like to welcome to Retina Synthesis Dr. Ashkan Abbey. Ash, welcome.
Thanks for having me.
Dr. Abbey is Director of Clinical Research at Texas Retina Associates in Dallas. And at ARVO, he presented the results of the GALE extension trial of pegcetacoplan, the Apellis drug, Syfovre. Can you tell us a little bit about the GALE study?
Yeah, so the GALE study is an extension of the two phase 3 clinical trials that were the pivotal trials for the FDA approval of pegcetacoplan for the treatment of geographic atrophy. Essentially, those were 2-year trials, and all of the patients who were enrolled in those trials had the option to roll over into GALE, which is a 3-year long-term extension study. And this study specifically is going to treat every patient that rolls over into it. So in the Derby and Oaks trial, most are familiar, they had 4 different groups. They had 2 treatment groups and 2 sham groups. The treatment groups were either monthly pegcetacoplan treatment or every other month pegcetacoplan treatment. And the sham groups were monthly sham injection or every other month sham injection. So for the monthly pegcetacoplan group, they were rolled over to get monthly pegcetacoplan again in the GALE study, and that'll be for 3 years. The every other month pegcetacoplan group got every other month pegcetacoplan, and the sham group, both of those groups got rolled over into pegcetacoplan treatment, either monthly if they were sham monthly or every other month if they were sham every other month. And so when those patients were rolled into GALE, they had to be compared to essentially a projected sham because there was no longer an actual control group in this trial. And that projected sham was just based upon the rate of growth of the sham group GA lesions in the previous Derby and Oaks trial. And what they saw was that roughly the rate of growth was about 2 millimeters squared per year in GA growth per year for those patients. And so they were able to just project out that same rate of growth linearly to the projected sham for year 3. And that's what we're looking at right now is the 12-month data, basically 3 years total of treatment for some of these patients, but the 12-month of the extension trial, that's the analysis we looked at and presented at ARVO.
So the take-home message that I got was the longer you were treated, the better the treatment results were.
Yeah, and that kind of panned out really well with the GALE trial. So when we look at those kind of standard linear curves that we have comparing the GA growth rate of the treatment group versus the sham group, you see the space widening even more between the control group, the projected sham control group, and the treatment group in year 3. Roughly the reduction in monthly treatment of the rate of growth was 35%. With every other month treatment, it was 24%. And so that was at 3 years total for treatment. And if you actually isolate specifically just the non-subfoveal lesions, the ones that are just not involving the center point of the fovea, those responded even better. We know those lesions tend to grow a lot faster compared to those that are involving the foveal center. And those lesions actually had a 42% reduction in GA growth at 3 years and with monthly dosing, and a 28% reduction at 3 years with every other month dosing.
So there were some visual acuity results too, correct?
Yes, and so this was interesting. I think there were some good post-hoc analyses done. You know, everybody really, I think it's kind of a hot topic when it comes to GA is that are we really doing anything for people's long-term visual acuity? And these post-hoc analyses were interesting because they, number one, they looked specifically at the progression of patients to what we would call severe visual impairment. And severe visual impairment is defined by the World Health Organization as less than 2200 vision. And so they looked at the patients from Derby and Oaks, essentially for the 2 years, and saw that the risk reduction in terms of they did a time to event analysis to see how long it took for the people to get to this less than 2200 vision. And the risk reduction with the patients being treated monthly of progression to severe visual impairment, that less than 2200 vision, was 38% with monthly dosing. And so pretty impressive number to show that we are actually affecting at least the progression to severe vision loss over time. Something else to be considered with respect to this post-hoc analysis that was interesting is looking specifically at microperimetry. And I think this is the most interesting part of the post-hoc analyses that have been done so far on at least the Derby and Oaks data. What they look specifically at, we know that microperimetry has probably the best correlation with, in terms of visual markers, with GA area. We've seen that from the chroma and spectry trials as well. It does much better than, say, best corrected visual acuity and other kind of markers like even the low luminance visual acuity. Microperimetry really can accurately correlate with GA area. So they looked at the microperimetry that was done in the Oaks trial, and they saw that if you specifically look at the central 4 loci on microperimetry, and you look to see if there are absolute scotomas in all 4 of those loci. So that's basically the central subfield that correlates to central subfield. If all 4 of those loci have about a 0 to -1 decibel reading, an absolute scotoma in those areas, that correlates with a significant worsening of vision compared to those that have even just one of those loci still functioning higher than the scotoma, so having some sort of sensitivity on the microperimetry. So they took the patients and they looked at the risk reduction to progression of an absolute scotoma in all 4 of the central loci versus those that had at least one that was maintained. And they found that the patients who were receiving pegcetacoplan had a roughly 36% reduction in terms of risk to progression to absolute scotoma development in all 4 of the central subfield or central loci, the 4 central loci on microperimetry. So again, that's kind of showing us that we are significantly reducing our risk of significant central vision loss here using the pegcetacoplan over the course of 2 years. Now, they also expanded it out to do the same analysis for the central 16 loci on microperimetry. And again, the same concept applied. Even if just one of the loci was found to have some sensitivity of more than 0 or -1, then it was counted as somebody who actually did not have a complete absolute scotoma. But for the progression to absolute scotoma in that central 16, which corresponds to the entirety of the fovea, essentially, we see again a significant reduction in risk of about 48% of progression to absolute scotoma in those central 16 loci. So the microperimetry data really helps to show kind of the massive change that we can have and massive in prevention of vision loss with treatment with pegcetacoplan.
Well, this is compelling data. How long will the GALE extension study go?
It's going to go for a total of 3 years. So once we're complete with all of our patients, and some of them have actually already completed the five years of total study, but essentially it was the 2 years of treatment in Derby and Oaks if they were in the treatment group, plus 3 additional years of treatment in the GALE study. So a lot of the patients will end up having 5 total years of treatment, which I think will be a fantastic data set to analyze once we have all the patients rolling out of the study. But December of last year, we had our first patient complete the entirety of the GALE study. We have more coming, obviously, in the next year or so.
What about retinal vasculitis?
Yeah, so safety is really an important thing to consider, obviously, when we're treating our patients here. We obviously have a signal in the community of retinal vasculitis. What's interesting is still in all of the trials that have been performed right now with all the trial patients that have had injections, we have not had a single case of vasculitis within the clinical trial setting. Now, we do know that there is in the real world a rate of about 1 in 10,000 total injections of vasculitis, and that still has remained consistent so far from the reporting that we have from Apellis. Also, we do know that this is primarily a first injection phenomenon, and so if we narrow it down to just the first injections, we can say the incidence is about 1 in 4,000 of vasculitis of first injections with this Syfovre injection.
So how do you use Syfovre in your own practice these days?
Yeah, so for me, it's I am not one to try to do this monthly. I think for me, it's too much burden on the patient. I think it's also, we know that monthly injections do increase the risk of conversion to neovascular AMD, more so than every other month dosing. I just think that overall, the risk profile and the kind of treatment burden that it imparts on a patient kind of lends itself to going more towards, say, 6 to 8 week dosing. And so I'm mostly doing every other month dosing for my patients. And I start right away because we have data from Apellis from the Derby and Oaks trial that justifies using it every other month from the beginning and shows its efficacy from the beginning as well. So when I am using it, I do consent the patients. I have them think about things before. I don't usually give an injection on the same day that I see a patient for the first time with GA. I'm usually giving them some material from Apellis about what the treatment entails. And then I also extensively go through a risk-benefit ratio analysis with them, where I'm very upfront about the fact that there are these vasculitis cases that can cause permanent vision loss. But I think it's a really nuanced conversation. It's not one of these conversations that we normally have about wet AMD, where we say, well, you have a net, you have blood, or you have fluid, you need treatment. If you don't get treatment, we're not going to be able to improve your vision. And it's not going to be, you have to do something here. This is one of those conversations where you say, it's okay if you don't want to do the treatment. It's okay if you want to just continue on, moving along at the rate that you're going with the GA progression, and you don't want to do these injections every other month or every 6 to 8 weeks, and it's just too much on you or your caretaker. So it's, I think, a longer conversation. I think it requires a lot more discussion about risks, and it does, I think, require us to not be, say, as aggressive and saying treatment has to happen. It's one of these things where I think it's much more up to the patient.
So in bilateral cases,
Mm-hmm.
okay, which eye do you treat first?
Definitely, I always treat the worst seeing eye, the one with the larger GA lesion. And I've even had cases where I've treated the worst seeing eye I probably would not continue treatment on going forward. Let's say it's a large lesion that's, say, almost arcade to arcade GA, but the other eye is the one that we really want to try to preserve. Let's say maybe that one has a foveal sparing lesion. I usually will start with the poor seeing eye just to make sure we don't have any sort of inflammatory response at all. If it doesn't have a response, then I'll go ahead and feel comfortable maybe a month or so later treating the fellow eye and going forward with that. But I always treat the worst seeing eye first, just to make sure I'm not seeing any sort of signal for inflammation or vasculitis.
Will you continue treating the worst seeing eye?
Probably in a case like that, I say no, actually. But there's other cases where I would, if the patient still believes they're using that vision somewhat around the center, then I'd be okay with it if they're wanting to do that. But I recently had a case where patient was count fingers, arcade to arcade. I stopped treatment after the first one, just after I saw that there was no signal for inflammation, and just continued for treatment for the better eye.
In the retinal vasculitis cases in the community, virtually all of them were on the first injection, correct?
That is correct. Yeah. And so we listed it in our presentation in ARVO that we've been quoting about a 1 in 4,000 incidence for first injections. And then the overall injection incidence in the community has been 1 in 10,000. And they've done over 215,000 injections now overall, both in the trials and in the community together. And so we're still seeing the rates roughly about 1 in 10,000.
What's left to be learned from the GALE extension study, do you think, going forward?
I think that it's going to be interesting to see how so one thing we didn't address in terms of the safety was also the rate of the ischemic optic neuropathy, which is roughly about 1 in 2,000 right now. And that usually has happened later on in the process with these injections. I'm going to be interested to see at the, say, 4 or 5 year mark with these patients, if it's starting to happen a little bit more often or not. If there's some sort of an effect from repeated injections, maybe leading to this happening. We know that in the majority of the cases that have been reported in the trials, they've had a disc at risk. They've had other risk factors that would lend themselves to getting ischemic optic neuropathy like that. But I'm just wondering if there is some sort of interplay with having multiple injections over time, or many injections over time, of this specific drug, and how it could potentially increase the risk for ischemic optic neuropathy. Otherwise, I'm actually very interested in seeing if this treatment effect continues to expand over time, if we're seeing that continuing widening of the space between, say, a projected sham and the treatment group as time goes on with our treatment.
Do you think the treatment effect is amplified with time?
I think what we're seeing is just that we are substantially dampening the inflammation at that junctional zone, where we would be getting more apoptosis, more kind of cell death over time. So as we continuously dampen that complement pathway and reduce the inflammation in that area, I think it just kind of potentiates itself to reduce the overall risk over time.
Well, great. Thanks so much for your participation in retina synthesis. This is an important topic. And I think you've provided compelling data that Syfovre is something that should be considered in the management of geographic atrophy.
Thanks so much for having me. I really enjoyed it, Carmen.
Thank you, Ash.